Evening, everybody. Can I just get somebody to pop into the chat if they can hear me or not? Okay, or give me some indication. Hi, everybody. I can see we've got some more people filtering in now. Can somebody just give me a thumbs up in the chat or some sort of indication if you are able to hear me or not? Thank you. I see somebody's giving me a thumbs up to that message, so I assume that means we're good to go. If anybody can't hear me, just let me know. We'll give it another couple of minutes just for people to start filtering in, and then we'll kick off if that's all right. Okay, I can see we've still got some people trickling in here. People should be joining in the next couple of minutes. So the next issue is, can everybody actually see my slides up on the screen? If somebody's able to give a thumbs up in the chat if you can see them okay. Oh, great. Thank you very much. So slides are working, audio is working. We're off to a good start. Okay, I think I'll give it another 2 minutes and then we'll start the presentation. Still see we've got another couple of people trickling in there. Okay, I think we'll make a start at this stage, and if anybody else trickles in from now, then they're still very welcome. Okay, everybody, good evening. Thank you all very much for coming. I hope the weather is better where you all are than it is here in Belfast. We are currently getting covered in snow. So my name's Hannah Kerr. I am currently an F1 doctor working in the Mater Hospital in Belfast. I have a particular interest in obs and gynae. It's what I'm hoping to specialise in. And I'm here tonight to give you a rundown of antenatal care in preparation for what I assume will be most of your final year medical exams. We might have some third or fourth years here as well if they're particularly keen. If so, you're very welcome, but it is a mostly finals focused presentation. So let's make sure so if has that slide moved on okay for everybody? I'm seeing a slide on learning objectives, if that's what you're all seeing. Yeah, good. Okay, so slides are moving okay. So just a brief overview of what I'm aiming to cover tonight. So I'm going to give you a rundown of what is considered routine antenatal care here in the UK. So what we offer to every single pregnant person who presents to maternity services. I will talk about the management of some chronic conditions in pregnancy. That's going to include diabetes and epilepsy, as well as a couple of other less common ones. I'm going to talk a bit about gestational diabetes, gestational hypertension, preeclampsia, and the management of those. I'm going to talk about how to manage a baby with breech presentation in the antenatal period and the management of rhesus disease. Obviously, there are a few topics relating to antenatal care that we can't cover in this presentation, unfortunately, due to limited time. But I hope you do find this selection useful for your finals, both written and OSCEs. So, women or anyone who gets pregnant in the UK can either self-refer to midwifery services or can be referred by their GP in this following confirmation of a positive pregnancy test. Their initial contact with maternity services will usually be at the booking appointment, and ideally we want this to occur around 10 weeks gestation. Prior to this, any problems relating to the pregnancy would be referred to the Early Pregnancy Problems Clinic. That would be things like bleeding early in pregnancy, suspected miscarriage, ectopic pregnancies, things like that. They will all be covered in a separate talk later in this series. But for most women who have a normal pregnancy with no issues, this will be their first contact with maternity services. The booking appointment is quite a long, quite extensive appointment. If you haven't had the chance to sit in on one of these appointments over the course of your studies, it's really a useful thing to see. It gives you a really good overview of everything that we look for in order to guide what we need to do to manage this pregnancy, level of care, level of monitoring, allows us to assess for risk factors for various things so we can put in place prophylaxis. So what will happen at this booking appointment? It usually takes at least an hour, if not more. So the pregnant person will be seen by either a midwife or consultant obstetrician or both. At this appointment, then, we will review the person's medical, surgical, and obstetric history. So we're looking for any medical conditions that might significantly impact the pregnancy, that might lead us to monitor the person more closely, to monitor the baby more closely. Any medications that we might have to alter or change. We're looking at surgical history to determine, the level of risk that might occur in terms of if we need to consider a cesarean delivery. And then we're looking at obstetric history. Has this person been pregnant before? What was the outcome of that? Were there any complications that we need to be worried about this time around? Is there anything else there that puts them at higher risk for complications in this pregnancy? And all of this information, we use that to guide to guide us in what risk category this person falls into. So can they safely be allowed to go to midwifery-led care, where they will probably never see an actual doctor for the rest of their pregnancy if everything goes well? Or does this person need to come under shared care with an obstetric consultant? That would be for slightly higher risk pregnancies where we're worried that things might not go 100% to plan. We also look at the social history. Social history is very important in pregnancy because there are a lot of things there that can influence the level of risk for the woman, the level of risk for the baby, and their engagement in services. And obviously there are things that we can do to optimize those. So obviously we want to know if the woman is a current or previous smoker. First and foremost, so that we can encourage them to stop if they haven't, so that we can offer support in doing that, and also so that we know if the woman continues to smoke during pregnancy, that would put them at higher risk of things like preeclampsia, placental dysfunction, and so we would want to monitor that pregnancy a little bit more closely, and they would probably come under shared care. We want to know about alcohol use. Does the woman have significant struggles with alcohol or substance use that we can put support in place for throughout the pregnancy? And again, it might lead us to monitor the pregnancy a little bit more closely, monitor the fetal well-being. We obviously want to check in regards to mental health. Does she have any mental health history that would obviously put her at higher risk of struggling with her mental health, both before, during pregnancy and after delivery? If that's the case, then again, we can put supports in place, we can put safeguards in place. Additionally, if she's on any medication for her mental health, such as an SSRI, or for women with bipolar disorder, things like lithium, those obviously have to be looked at during pregnancy. And we also want to check in with every pregnant person if everything is nice and safe in the home, that there are no issues regarding things like domestic abuse, domestic violence, that we need to be concerned about. In terms of examination then, we want to look at the height and the weight to enable us to calculate a BMI. So a raised BMI would put the woman at higher risk of, again, things like preeclampsia, gestational diabetes, and VTE, venous thromboembolism. So we might need to consider prophylaxis for things like that if the woman has a particularly raised BMI, especially if there are other risk factors. We also look at the blood pressure. So even though, as I'll talk about, gestational hypertension and preeclampsia can't be diagnosed before 20 weeks gestation, we still look at the blood pressure at this booking appointment, even though the woman's only at 10 weeks, because if that is raised, again, it's a risk factor for going on to develop preeclampsia, and we might need to consider starting the woman on antihypertensive medication if she's not already on it, to reduce that risk, as well as aspirin prophylaxis. We'll also do a urinalysis to get a baseline. We're looking particularly for any protein in the urine and for anything that might indicate infection. So pregnancy is one of the only times in which we will actually set out to actively treat an asymptomatic urine dip if it's positive for like bacteria, leukocytes, nitrites. Pregnancy is one of the only situations in which we would go ahead and treat that, even if the woman is not symptomatic at all, because there's an increased risk of that infection, if there is one present, spreading upwards and causing a pyelonephritis, which can cause potential complications for the pregnancy down the line. At this appointment, the woman will then also be risk assessed for VTE, venous thromboembolism, for gestational diabetes or GDM, and for preeclampsia, and if necessary, prophylaxis put in place. She'll have bloods taken. She'll have a full blood count taken at that booking appointment to check for anemia. And that will also be repeated at the 28-week appointment. And there are hemoglobin targets based on gestation. if the woman dips below those targets, we might need to think about starting some iron supplementation. So in the first trimester, the target is 110. In the third trimester, that goes down to 105, and after delivery, under 100. That's the stage at which we would start to consider iron supplementation. The woman will then also be screened for some communicable diseases such as HIV, hepatitis B, and syphilis, as well as for hemoglobinopathies, such as thalassemia and sickle cell disease, because obviously, again, those are things that will influence the risk category, the timing and the mode of delivery, and that we might need to consider treatment for during the pregnancy. And then, as I said, we take all this information and it allows us to determine the risk category of the woman, whether she can go to midwifery-led care or if it has to be shared care with a consultant. So after this booking appointment, then there are further appointments at 28, 34, 36, 38, and 41 weeks. And as you can see there, those appointments obviously increase in frequency the closer that we get towards term. For nulliparous women, so that's women who have never had a baby before, this is their first pregnancy, they will also have they will start their appointments earlier, so at 25 weeks, and they will also have them more frequently. So they'll have additional appointments at 25, 31, and 40 weeks. At every appointment, whether that be with the midwife or with the obstetrician, these are the things that will be monitored. So we'll look at the blood pressure again to screen for any signs of developing preeclampsia. We'll look at urinalysis. Again, we're looking for both proteinuria that might also indicate preeclampsia, and we're also looking for signs of infection that we might need to treat. We will measure the subphysiofundal height as a minimum. That usually starts at about 25 weeks, and we'll plot that on a customized growth chart, and that just allows us to keep an eye on how a baby's growing to make sure that this isn't a baby that is particularly small or particularly large for their gestational age. Both of those can be a sign of potential complications. We'll again check in on the woman's general health, how she's coping with the pregnancy, if there's anything that has changed with her health, any new medications that we need to be aware of. And we'll also check in on how often and how frequent the fetal movements are. They will usually start at about 18 to 22 weeks. Most women will start to notice baby moving. And obviously we want to be alert for any change, any decrease in the fetal movement. We will also discuss, again, the mental health of the woman, check in, is she coping well with the pregnancy? We'll again check in regarding safety in the home in terms of domestic violence. And we'll also, increasingly as we get towards term, we'll also start to talk about birth planning. Obviously, elective cesarean sections are something that are permitted in the UK. So as term approaches, it's always a good idea to check in with the woman regarding what would her ideal birth be. Does she want to be allowed to go into labour naturally? Would she prefer an elective induction or an elective cesarean section? And again, that will all be guided by her well-being and the well-being of the baby. So a note on folic acid then during pregnancy. So folic acid is obviously recommended for all women planning pregnancy, and I say planning pregnancy because we want to start folic acid prior to conception. Okay. By the time most women realize that they are pregnant, the time frame in which folic acid is going to benefit the developing fetus has already passed. So any woman who's actively planning a pregnancy should be encouraged to supplement with folic acid. And we want to continue that folic acid until the pregnancy has reached 12 weeks of gestation. For most women, that folic acid will be at a dose of 400 micrograms per day. However, there are some women who are at higher risk of neural tube defects, which is the aim of taking folic acid. We want to decrease the rate of neural tube defects. Women who will be in this higher risk category will be women with significant obesity, women who are diabetic, women with epilepsy, particularly those who are on anti-seizure medications, where there is a family history of neural tube defects in either partner. So that would be things like spina bifida, anencephaly, hydrocephalus. any history of any of those things would put the pregnancy at a higher risk of a neural tube defect. And if there's any hemoglobinopathy or hemoglobinopathy trait, so such as sickle cell disease or thalassemia, all of those would put the pregnancy at higher risk of developing a neural tube defect. And so we want an increased dose of folic acid in those scenarios. So that would be at a dose of 5 milligrams every day. So important scans then during the pregnancy. So scans are probably the things during pregnancy that the expectant couple will be most anxious about and most excited for. It's really their only opportunity to see their developing baby, to bond with them prior to delivery. They're also very important for us as medical professionals. They give us a really good idea of how the pregnancy is progressing, allow us to monitor for any potential complications. So the 2 routine scans that every pregnancy will receive are, first of all, the dating scan. So the dating scan will take place usually at the booking appointment, if the booking appointment isn't too early in the pregnancy to do that. It should take place between 11 and 14 weeks of gestation. And this scan has a couple of functions. First of all, it allows us to determine the gestational age and estimated due date, and we do that using crown rump length. At this gestation, later on, we can use things like head circumference, abdominal circumference, and femur length. But at this early stage, the fetus is not developed enough to allow us to do those things. So we use crown rump length to determine the age and also to get an estimated fetal weight. The dating scan also allows us to confirm whether this is a singleton pregnancy or a multiple pregnancy, so twins, triplets, or higher order than that. And finally, it allows us to measure the nuchal translucency, and that's as part of antenatal screening for Down syndrome, which I'm going to talk about shortly. Then we have at 18 to 21 weeks what is commonly referred to as, at least here in Northern Ireland, the big scan or the fetal anomaly scan. So as I said, this should take place at around 20 weeks gestation, 18 to 21, and it is a comprehensive assessment of the fetal anatomy. So we're looking for things like neural tube defects, spina bifida, anencephaly, hydrocephalus. We're looking for things like congenital diaphragmatic hernias, gastroschisis, exomphalus, congenital heart diseases, skeletal dysplasias, and cleft lips, among a multitude of other conditions. It also allows us to check for placental positioning. So if the placenta is particularly low-lying, then that's obviously something that will need to be monitored going through the pregnancy to make sure that it rises to the appropriate position. And if not, there's some precautions that we may need to take during delivery, up to and including the recommendation for a cesarean section. But again, that will all be covered in a separate lecture later in this series. So I said I would talk a little bit about antenatal screening for trisomy 21, also known as Down syndrome. So this should be offered to every pregnant couple in the UK. They have the absolute right to decline that screening should they wish, but if it is something they want, then it is something that we can go ahead and offer. There's a couple of different options for screening for trisomy 21, and which one we go for all depends on the gestation of the pregnancy. So between 11 and 14 weeks, we can perform what's called the combined test as first line. And the combined test is a combination of maternal blood tests and an ultrasound scan. Usually, this ultrasound scan will be the dating scan that we use. And we're looking for increased nuchal translucency on that ultrasound scan, higher nuchal translucency. So the nuchal translucency, you're measuring the fat pad at the back of the fetus's neck. And the more translucent it is, that gives an increased risk of the fetus having Down syndrome. And then things that we're looking for in fetal blood, in the maternal blood tests, would be increased levels of beta-HCG, or the pregnancy hormone, and reduced levels of pregnancy-associated plasma protein, or PAPA. Combining all of those three factors together, we can estimate the risk of the fetus having Down syndrome. If we get a little bit later on in the pregnancy and the woman maybe initially decided that she didn't want screening but now would like it, or if she's booking late, then between 14 and 20 weeks, we can offer what is called the triple test. The triple test only involves maternal blood tests. There is no scanning involved. And we measure three things. We measure, again, the beta HCG. We measure alpha fetoprotein, which some of you might know is a tumor marker for things like hepatocellular carcinoma or testicular cancer. But in pregnancy, we use it as part of the triple test. And estriol levels. And an increase in HCG combined with low AFP and low estriol all indicate an increased risk of that fetus having Down syndrome. So what do we do in these scenarios? So these screening tests allow us to provide the woman with a risk category. So we either categorize them as higher risk of Down syndrome or lower risk of Down syndrome. If the woman is put in if the woman's test results indicate that she's in that higher risk category, so that there is a greater than 1 in 150 chance of her fetus having Down syndrome based on those results, then we offer further testing. And again, what we offer is based on gestation. So any earlier in pregnancy, so before 15 weeks gestation, we offer CVS or chorionic villus sampling. And basically what this involves is a biopsy of the placental tissue that's done under ultrasound. Any later than 15 weeks, so greater than 15 weeks in pregnancy, then we would not offer that. We would offer instead amniocentesis, and that involves, again, ultrasound guided aspiration of the amniotic fluid. Now, these tests they're very good tests. They allow us to send samples of these tissues for karyotyping, and they will give us a definitive answer as to whether or not this fetus has Down syndrome or not. However, they do involve risks. There is increased risk of infection, of rupture of the amniotic sac, of preterm labour. So that has to be the woman's decision as to whether or not she wants these tests. And again, she has every right to decline them. The other option for follow-up these tests is non-invasive testing, which just involves maternal blood tests, but unfortunately that's not currently offered in the UK under the NHS. Women should still be informed about it though, because it is an option if they want to go privately for that. Obviously it's much lower risk than the other two procedures. Unfortunately, the reason the NHS doesn't offer it is, as with most things, it's purely an issue of funding. They're quite expensive tests, so that's why it has to be done privately if that's the route the woman chooses to go down. So vaccinations then are another important part of antenatal care, and these are going to protect both the woman and her developing fetus as well, and which will become the newborn baby when it's born. So it offers protection in all of those situations. So we divide these into two categories. So there's the vaccines that we want the woman to have had preconceptually. One of the most important ones is her MMR vaccine. So if we have a woman who is planning a pregnancy and she has never had an MMR and she is negative for rubella antigens, so she's never been antibodies. She's never been infected with rubella before. Then that would put her baby at increased risk of congenital rubella syndrome if she should come in contact with that infection while she's pregnant. So ideally, we would want to offer her the MMR vaccine prior to conception. Similarly with the varicella vaccine. So if we have a woman who is planning a pregnancy, she has never had, there's no history of chickenpox infection, and she has certain risk factors. So those would be, she has occupational exposure to chickenpox, which would be all of us as healthcare professionals, or she's the household contact of an immunocompromised person. Then we would offer a varicella vaccine prior to conception, but only if she has those two risk factors that I've mentioned. It's not routinely offered to every woman planning a pregnancy. And it also shouldn't be offered if there is a confirmed history of chickenpox infection. The hepatitis B vaccine should also be offered to women prior to conception if they fall into certain risk groups. So that would be women who are IV drug users, who have chronic liver or renal disease, or who have frequent changes in sexual partners, or who are in regular contact with someone with an active hepatitis B infection. The important thing to note, though, is that these are all live vaccines, so we don't actually offer them during pregnancy. They can only be given preconceptually, and the woman should be advised to actually avoid becoming pregnant for at least a month after each of these vaccines. So although they are an important part of preconception care, once conception has occurred and the woman is pregnant, it's too late for any of these to be given, unfortunately. Then there's a set of vaccines that we give routinely during pregnancy. So the first would be whooping cough, pertussis, and that's given routinely at 16 weeks gestation. Then, as of September this year, so this is quite a new development, we now offer all women an RSV vaccine at 28 weeks pregnant, and that will protect both her and her newborn baby from RSV infection. Any of you who have been on your paediatric placement know what a horrible infection that can be for young babies. And then all pregnant women should also be offered the seasonal flu vaccine if their pregnancy occurs at the time of year when those are offered. And as I said, all live vaccinations should be avoided during pregnancy. So next bit I'm going to talk a little bit about is diabetes during pregnancy. So about 1 in 20 pregnancies are affected by diabetes, so it's quite a common thing that maternity services have to deal with. The majority of these are going to be gestational diabetes, and that's as a result of decreased insulin sensitivity during pregnancy, and that's mostly related to hormonal fluctuations. Women who are either have pre-existing diabetes or who develop gestational diabetes, they're at an increased risk during both during pregnancy and during labour and delivery. Increased risk of things like preeclampsia and stillbirth. And then during labour, there's increased risk of shoulder dystocia, largely due to macrosomia. And then after birth, there is the risk of neonatal hypoglycemia, which has seen a lot of babies end up in the neonatal ICU. These risks can be reduced, but they cannot be completely eliminated. And that's why it's so important that these women are provided with good quality education, counselling on the importance of good glycemic control during pregnancy. So, ideally, a woman who has pre-existing diabetes, her pregnancy would be pre-planned, and that will enable us to optimize everything so that she can have the most successful pregnancy possible. So we want the glycemic control to be as good as possible, and we want to optimize any complications that she might have from those diabetes. So the first thing we want to do is we want to check the HbA1c, and we're aiming for a HbA1c of less than 48 millimoles per litre. That would indicate good glycemic control and reducing the risk of complications during pregnancy. We want to encourage the woman to lose weight if her BMI is greater than 27. As I've mentioned before, she'll need an increased dose of folic acid from the moment she starts planning that pregnancy up until 12 weeks of gestation. And then she'll also need an up-to-date renal and retinal assessment to assess for any complications of diabetes. Part of that preconception counselling should also involve a medication review. So a pregnant woman with diabetes, her diabetes must be managed exclusively on metformin and insulin. Okay. All other oral hypoglycemic agents are not safe to use during pregnancy. And then you also want to look at any medications that she might be on for the complications of diabetes. So things like ACE inhibitors and ARBs that they might be on for hypertension, statins that they might be on for high cholesterol. All of those have to stop during pregnancy. Antenatally then, all of these women automatically fall into the high-risk pregnancy category, and so they cannot go just to midwifery-led care. It has to be shared care under an obstetric consultant, and contact should be made at least every 1 to 2 weeks. We're aiming to maximize glycemic control, and you can see the targets over on the left-hand side here in this little table. We're aiming for a fasting glucose above 5.3. and a 1 hour post-meal glucose of less than 7.8. And we always want that blood sugar to be greater than 4. We want to minimize the amount of hypos that these women are experiencing. They should be encouraged to monitor their blood glucose at least 2 to 4 times a day. So that's prior to every meal and before bed. If they're not already on a continuous glucose monitor, which most diabetics are at this stage, particularly type 1 diabetics, as the technology is evolving and becoming more accessible, that's becoming much more common. But if they don't already have one, if a woman with type 1 diabetes becomes pregnant, she should absolutely be offered that. Or a woman with type 2 diabetes who has particularly unstable blood glucoses, they should all be offered continuous glucose monitoring with things like the Freestyle Libre or the Dexcom. And it's important to note that during pregnancy, the woman might have a decreased awareness of any hypoglycemic episodes during pregnancy. So hence why increased monitoring of the blood glucose is important. Antenatally, then, they should have a retinal assessment at their 28-week appointment. They should also be offered one at booking if their previous one was greater than 3 months ago. They'll need ultrasound monitoring for fetal growth every 4 weeks once they reach 28 weeks gestation up until 36 weeks. And then from 38 weeks on, they're going to need a weekly assessment of fetal monitoring. So that's going to involve ultrasound scans for an estimated fetal weight to track fetal growth, umbilical artery Dopplers, amniotic fluid indexes, and CTG. That all has to occur weekly once they hit 38 weeks. So a little bit about gestational diabetes then. So you can see here we've got a list of risk factors and potential features that you might see in these women. So the risk factors would include gestational diabetes in a previous pregnancy, a woman who is obese with a BMI of greater than 30, a woman who's had a previous macrosomic baby weighing greater than 4.5 kilos, a first-degree relative with diabetes, or women from a certain ethnic background, so women who are Black, Middle Eastern, or South Asian. These all are higher risk populations for gestational diabetes. All of these women who fall into any of these categories, even one risk factor, should be offered an oral glucose tolerance test between 24 and 28 weeks, 24 and 28 weeks. So this test basically involves they come in fasting, they have their blood glucose tested initially, they will then be given what I'm told is not a particularly nice tasting drink, quite a sugary drink containing 75 grams of glucose. They'll drink that, and then 2 hours later they will have their blood glucose tested again to see how it responds. And to remember the cutoffs for diagnosis of gestational diabetes, go back to your step song, 5, 6, 7, 8. So if fasting glucose is greater than 5.6, or if the glucose is greater than 7.8 2 hours after that drink, then we can make the diagnosis of gestational diabetes. Some features that we might see in these women is a fetus that is large for gestational age. You might see polyhydramnios, or an increased volume of amniotic fluid, or a significant glucosuria. So what we class as a significant glucosuria would be testing of 1+ on the urinalysis on 2 occasions, or 1 incidence of a testing of 2+. If it's just a one-off of 1+ or a trace of glucose, that's not clinically significant. That can be a normal finding during pregnancy, a transient glucosuria. But if it's persistent or if it's more significant, that woman should also be offered a glucose tolerance test. Managing gestational diabetes, largely the same as the management of pre-existing diabetes. So if her initial fasting glucose at that glucose tolerance test is less than 7, she can attempt to control that gestational diabetes just through dietary measures. We then monitor that over the course of 2 weeks, and if the blood glucoses are still not at the targets that we discussed previously, she should be offered metformin. And again, that should be for a trial period of 2 weeks. Following that, if the blood glucoses are still uncontrolled, she should be offered insulin then. If the fasting glucose then on the glucose tolerance test is greater than 7, or if there are features of macrosomia or polyhydramnios, so that indicates a more significant gestational diabetes, and that woman should be started on insulin straight away, obviously with the addition of dietary measures, and then metformin if needed, if the blood glucose levels are still raised on the insulin. Some considerations then during labour and delivery. So women with diabetes, whether gestational or pre-existing, delivery should be something that's discussed with them a little bit earlier than some women. The timing and the mode of the delivery are both things that are going to need to be considered. So for women with pre-existing type 1 or type 2 diabetes, we would recommend a slightly earlier delivery between 37 weeks and 38 plus 6. And that can be through induction of labour or elective caesarean section. Women with gestational diabetes, we can let them go a little bit longer, but we don't recommend that they go before 40 plus 6 weeks. And again, that's because women who are diabetic, they're at increased risk of placental dysfunction, fetal growth restriction, and then conversely also at increased risk of having a baby that is macrosomic, that is large for gestational age, which can increase the risk of complications during labour. They should be encouraged to deliver in hospital with access to a neonatal unit. And that's largely because, as I said, the babies of these women are at increased risk of neonatal hypoglycemia. And so they may well need monitored for that in the neonatal unit. And so that should be something that's easily accessible at the time of delivery. While these women are labouring, they're going to need hourly glucose monitoring. And we want to keep that glucose between 4 and 7. To achieve this, they may well need IV dextrose or IV insulin to keep this within range. Some considerations after delivery then. So for baby, as I said, they're at increased risk of neonatal hypoglycemia. So we want to prevent that as much as possible by feeding the baby as soon as the woman is physically able to after birth. If that's not going to be for a prolonged period of time, then formula supplementation should be encouraged until the woman's able to breastfeed if that's what she desires to do. We should check the blood glucose at least twice following delivery, at 2 hours and at 4 hours of life. And that baby should be monitored in hospital for at least the first 24 hours of life. For the mother then, insulin requirements, particularly for women who have pre-existing diabetes, they very often rise during pregnancy. As I said, pregnancy decreases insulin sensitivity. So pregnant women often need an increased doses of insulin. After delivery then, they are at increased risk of hypoglycemia because that insulin sensitivity rises again. So the dosages of insulin that had them perfectly controlled during pregnancy might be a little bit too much for them after delivery. So consideration should be given to reducing those down. Oral hypoglycemic agents, same during pregnancy, they should be avoided if that woman is breastfeeding. So again, it should be just metformin and insulin. Women who had gestational diabetes then during their pregnancy, we know that they are at increased risk of both type 2 diabetes later in life and recurrence of gestational diabetes in subsequent pregnancies. So we're going to offer them a fasting glucose test between 6 to 13 weeks after delivery. They should also have a HbA1c checked annually. And again, they'll be offered an oral glucose tolerance test in any subsequent pregnancy. So what about women with epilepsy then? So epilepsy is a common condition that affects younger people of childbearing age. So we do see quite a few pregnant people coming in with epilepsy. Again, as with diabetes, preconceptual counselling is really important, and outcomes tend to be better in planned pregnancies. It allows for medications to be adjusted, allows for starting preconceptual folic acid and safety advice to be given to those women, as well as advice on the potential complications during pregnancy. Conversely to that, then, the difficulty with that is that some medications used for epilepsy, such as carbamazepine and phenytoin, they interact with the combined hormonal contraceptive pill, and actually reduce its efficacy as a contraceptive. So they are at increased risk of accidental or unplanned pregnancies. And then, as I said previously, all women with epilepsy are going to need an increased dose of folic acid prior to conception up until 12 weeks to reduce the risk of neural tube defects. Ideally, epilepsy should be well managed before the woman becomes pregnant. And again, that should be on a single agent. The safest ones during pregnancy would be lamotrigine and levetiracetam. All other ones carry an increased risk of congenital malformations. The big culprit that I'm sure you have all had drilled into you many, many times is valproate, and that is absolutely contraindicated in any woman of childbearing age, unless there's absolutely no other suitable agent. But yeah, ideally, a woman planning a pregnancy should be controlled on just either lamotrigine or levetiracetam. Hormonal fluctuations, lack of sleep, stress are all a normal part of pregnancy, unfortunately. And these things do put the woman at increased risk of seizures during the pregnancy. So the seizure threshold can reduce. And to control that, she may need an increased dose of her epilepsy medication during pregnancy. Postnatally then, the woman should be given safety advice for both herself and for the baby. So that would involve things like not bathing the baby when she's in the home on her own in case of a seizure or while that happening. Not carrying the baby at the same time she's carrying things like a kettle where there's hot liquid involved. All of those would would increase the risk of injury to both herself and the baby should a seizure happen. And there have been some really, really tragic cases in the news of women with epilepsy killing or seriously injuring their baby through no fault of their own. It's something that's really sad to see. So appropriate safety counselling on that is needed. And then after delivery, she may need a reduced dose of her seizure medication if it was increased during pregnancy. A couple of other conditions to note then. Sorry, we're going back. Hypothyroidism then. So any woman with hypothyroidism should have an increased dose of levothyroxine. It's usually increased by 25 to 50 micrograms. We titrate that based on TSH levels, which should be monitored regularly during pregnancy. And the reason for this is that undertreated or untreated hypothyroidism puts the woman and her fetus in an increased risk of miscarriage, of intrauterine growth restriction, and of preeclampsia. So it's important that those TSH levels are kept steady. Women with rheumatoid arthritis, then their symptoms often actually improve during pregnancy, and a lot of them can safely and comfortably come off their medication. Unfortunately, that's not the case for all women, and they do still require some management for that during pregnancy. If that is the case, then the one that is absolutely contraindicated, as I'm sure, again, you have all had drilled into you, is methotrexate. So methotrexate is a folic acid blocker, so that would put the pregnancy at a significantly increased risk of neural tube defects if that were to continue. Other DMARDs, such as hydroxychloroquine, sulfasalazine, are all considered safe during pregnancy, as are steroids. So hypertension then during pregnancy can be split into essentially 3 different categories. So there's chronic hypertension. So that's raised blood pressure that exists prior to 20 weeks gestation. And again, that's why we monitor the blood pressure even going all the way back to the booking appointment. Gestational hypertension then is a new raised blood pressure, so greater than 140 systolic, or at greater than 20 weeks gestation with no evidence of proteinuria or of end organ damage. And I'll come on to that later, what that end organ damage can look like. Severe hypertension then can be classified as a systolic blood pressure of over 160 or a diastolic of over 110. And that's relevant to all 3 categories here that I'm going to talk about. The final category will be preeclampsia. So preeclampsia is a new high blood pressure at greater than 20 weeks gestation, but this time there is evidence of significant proteinuria of 1 plus or more, or of maternal end organ damage, or of uteroplacental dysfunction. So that can look like things like intrauterine growth restriction, a fetus that's small for gestational age, placental abruption, all things like that can occur during preeclampsia. So all women, as I said, at that booking appointment are risk assessed for preeclampsia, and we can see some of those risk factors here. So pre-existing hypertension, previous gestational hypertension, certain autoimmune conditions such as lupus, diabetes, or chronic kidney disease are all considered high risk of preeclampsia. And then a woman who's slightly older, so age greater than 40, a woman with a BMI of greater than 35, a woman where there's greater than 10 years between pregnancies, a multiple pregnancy, so twins, triplets, etc., a woman in her first pregnancy, or a woman with a family history of preeclampsia, they are all considered at moderate risk of preeclampsia. So when we're taking the history at the booking appointment, we look out for all of these things, and if the woman has one high risk factor or two or more moderate risk factors, she should be offered aspirin prophylaxis to reduce the risk of preeclampsia. That should be taken from 12 weeks gestation until after delivery. So it continues throughout the whole pregnancy. How to manage women with chronic hypertension then during pregnancy. So again, as with all pre-existing conditions, we want to go into the pregnancy with that as well controlled as possible. So we're aiming for a systolic blood pressure of less than 135 and a diastolic pressure of less than 90. As I said, she should be offered aspirin prophylaxis from 12 weeks until delivery. And then if that blood pressure needs to be controlled using medications, that's something that needs to be reviewed during pregnancy, because there are a lot of antihypertensives that aren't safe to use. So during pregnancy, the first line would be labetalol for raised blood pressure. If that's not enough, then we can or if labetalol is contraindicated. So, for example, if the woman has a history of severe asthma, then we would go to nifedipine, and then methyldopa would be third line. Again, medications like ACE inhibitors, ARBs, none of those are safe to use during pregnancy. And then the important thing to note is that all of these women need to come under consultant-led care. So they're not safe to go under midwifery-led, and they'll need regular monitoring of their blood pressure and urinalysis. So that blood pressure needs to be monitored. That blood pressure will need to be monitored at least 48 hourly. So preeclampsia then is, as I said, is a new raised blood pressure at greater than 20 weeks gestation, this time with evidence of end organ damage. So if a woman is diagnosed with preeclampsia, we've got a list of signs and symptoms to look out for that might lead you to that diagnosis. So any pregnant woman complaining of a headache, dizziness, blurry vision, or any sort of visual disturbances, or significant edema, should all be assessed for preeclampsia. So on the same day, so they'll need their blood pressure checked, they'll all need a urinalysis. And the important thing to note is that when we say edema, we're looking particularly at non-dependent edema. So dependent edema, which is edema related to just gravity, that's largely seen in the feet or sometimes in the hands. If the woman's been on her feet all day, that can be again a normal part of pregnancy, unfortunately. But if it's significant edema, or if it's in a part of the body where you wouldn't really expect, so for example, you might see some preeclamptic women with particularly puffy faces, especially around the eyes. That should lead you to assess that woman quite thoroughly for preeclampsia. Other signs that you might look out for on examination would be things like papilledema or hyperreflexia, so increased deep tendon reflexes, and that's as a consequence of increased nervous system excitability in preeclampsia. So again, if the diagnosis of preeclampsia is made, similarly to chronic hypertension, she's going to need frequent monitoring of that blood pressure. How often that's done is going to depend on the severity of the preeclampsia, but in an absolute minimum, it should be every 48 hours. She's also going to need regular assessments of fetal well-being. So we track the growth of the fetus, we assess the CTG, the umbilical artery Doppler, and the amniotic level of amniotic fluid, or the amniotic fluid index. And again, that happens at least every 2 weeks, if not more often. How often will just depend on how well that fetus is coping in that environment. The woman's going to need weekly blood tests to assess for end organ damage. So those blood tests should involve kidney function, liver function, coagulation screen. We're looking for things like kidney damage, liver failure, hemolysis. So she's going to need regular FBCs, thrombocytopenia, all things that would indicate increasing severity of preeclampsia. We're also going to need to monitor the fluid balance of preeclamptic women. A lot of these women will need to be put on a fluid restriction, particularly ones that are that do become quite edematous, quite swollen. And it's important to counsel the women that preeclampsia does increase the risk of a growth-restricted baby, of stillbirth, and of complications with the placenta, such as placental abruption. And she should be taught to monitor the fetal movements, and also educated on like the signs and symptoms of a placental abruption, so she can seek medical attention if needed. Management of preeclampsia then with medications for the blood pressure is exactly the same as we've mentioned before. So labetalol first line, followed by nifedipine, and then methyldopa. So if the woman then presents with severe preeclampsia, so a blood pressure of greater than 160 systolic or a diastolic of greater than 110, then we should really consider hospital admission for that. During that admission, we can obviously monitor her blood pressure, her well-being, and the well-being of her baby much more closely. We can also use IV medications if needed in order to control that blood pressure if it's particularly difficult to control on oral medications. So things like IV labetalol or IV hydralazine can all be used if that blood pressure just won't stay down despite optimum medical management. A severely preeclamptic woman is also going to need magnesium sulfate, and that's as prophylaxis for eclampsia. And that magnesium sulfate is given as a loading dose of 4 grams, followed by an IV infusion. If we're considering then preterm delivery for these women, then steroids should be given to aid fetal lung development. Now, I've put this little picture of a seesaw at the side, and that's just to represent the balancing act that we're trying to deal with here. So our aim is to get as close to term as possible. So when we deliver this baby is going to be determined by both the well-being of the mother and of the fetus. And the balancing act is really between the potential complications of allowing that pregnancy to continue as the severity of preeclampsia increases, and the potential complications of an early delivery. So we're trying to really weigh up the risks and benefits when we're considering an early delivery. Obviously, as we get closer to term, our threshold for delivering would decrease. If there's any signs of either maternal or fetal distress, then that would indicate an urgent delivery, whether that be through induction of labour or emergency cesarean section. The important thing to note is that if this woman does deliver vaginally, then ergometrin has to be avoided in the 3rd stage of labour. It's contraindicated in women with hypertension. So when you're in the 3rd stage of labour delivering the placenta, you want to go with other medications. So just a quick note on magnesium sulfate, which I mentioned briefly there. So as I said, it's given to women with severe preeclampsia or those who go on then to develop eclampsia, and it's a CNS depressant. So in preeclampsia and eclampsia, There's increased CNS excitability, which is why women with eclampsia will often have seizures. So this helps to counteract that. It's not perfect, though. There is a significant risk of toxicity. And so we want to monitor that woman very closely when that's being given. We're looking for things like reduced or absent deep tendon reflexes. We want to look out for pulmonary edema, so any signs of respiratory distress. And she also might need cardiac monitoring for any arrhythmias. If there are any signs of magnesium toxicity, then we would be given calcium gluconate as the antidote to that, and that absolutely has to be readily available if you have any woman receiving magnesium sulfate on the ward. After delivery then, so the delivery of the placenta is essentially the cure for preeclampsia and eclampsia, but some women can still then have ongoing issues after delivery. So within the first 24 hours after delivery, there's still a significant risk of seizures, especially if that woman had severe preeclampsia. And for that reason, if she was started on magnesium sulfate before delivery, that should continue for 24 hours after delivery. The blood pressure should still be monitored closely after delivery to ensure that it goes down. And if it doesn't, then she's going to need ongoing treatment for high blood pressure. What we use actually changes after delivery. So enalapril, whereas that would have been contraindicated before delivery, is now actually our first line in a woman who's just delivered and is hypertensive. It is safe to use if breastfeeding. If that's not enough, then next line would be again nifedipine. And we want to aim for a blood pressure of under 135 systolic. Medications then can be stopped or reduced as deemed appropriate if that blood pressure is consistently below 130/80. So next part of the talk is about rhesus incompatibility. So as I said, at the booking appointment, all women should have a group and hold done, a group and screen to determine their blood type, and within that we'll obviously get whether that woman is rhesus positive or rhesus negative. So for all women who that test comes back to indicate that they're rhesus negative, they will need routine anti-D prophylaxis during that pregnancy. There's two options for that. It can either be given as 1,500 units at 28 weeks gestation for a single dose treatment, or it can be given as 2 doses of 500 units at 28 and 34 weeks. And the reason that we're doing that is to prevent maternal sensitization to rhesus antigen. So if her fetus is rhesus positive and some of that blood leaks into the maternal circulation, her immune system will become sensitized to that. That process is irreversible once it's happened. So prophylaxis, stopping that from happening in the first place, is the most important thing. If that woman does become sensitized to the rhesus antigen, then if she subsequently has a second rhesus positive baby, that baby would be at risk of what we call hemolytic disease of the newborn, which can cause fetal anemia, high drops, and intrauterine death. So it's really something that you can't emphasize how important it is to prevent that sensitization from happening in the first place. So routine anti-D prophylaxis is given then to every woman, either as a 1-dose course or as 2 separate doses. Additional doses then may be needed depending on the events of the pregnancy. So if there are any potentially sensitizing events during pregnancy, then she'll need additional anti-D prophylaxis. So sensitizing events would be things that could cause increased fetal maternal hemorrhage, so crossing of the fetal blood into the maternal circulation. So examples of that are going to be a miscarriage or an ectopic pregnancy, an antepartum hemorrhage, any significant abdominal trauma, invasive procedures such as amniocentesis or chorionic villus sampling to screen for Down syndrome, external cephalic version if the baby has breech, and the actual process of labour and delivery itself. So after birth, if the baby's found to be rhesus positive, then an additional dose of anti-D will be needed. The dose of anti-D at that stage, again, depends on the gestation. So if that sensitizing event takes place at less than 20 weeks of gestation, then it should be given as 250 units. If later on in pregnancy, at 20 weeks gestation or more, it should be given as 500 units, slightly higher dose. Again, at greater than, I see that question, APH. So APH, that would be antepartum hemorrhage, so any bleeding prior to delivery. So if that woman has a sensitizing event at greater than 20 weeks gestation, then you want to run a Kleihauer test. So a Kleihauer test determines the degree of any fetal maternal hemorrhage, so how much of that fetal blood has entered the maternal circulation. And essentially how that works is you take a sample of the maternal blood, and fetal hemoglobin is more resistant to acidic conditions than normal hemoglobin, the hemoglobin that we have in our blood. So during a Kleihauer test in the lab, they will apply a sample of acid to that blood sample, and that will essentially destroy any maternal hemoglobin in that sample and leave only any fetal hemoglobin that will remain. And that gives us an idea of how much, if any, fetal blood crossed into the maternal circulation. If it was estimated to be greater than 4 mils of fetal maternal hemorrhage, then an additional dose of anti-D prophylaxis is required on top of what would have already been given at the sensitizing event. And anti-D prophylaxis should be given within 72 hours of any sensitizing event. So finally then come on to breech presentation. So breech presentation is any presentation that is not cephalic, so not head down, where the presenting part isn't the fetal head. There's 3 different types. So we can have a complete or flexed breech, in which one or both of the fetal knees are flexed up towards the abdomen. We can have a footling breech, or also known as an incomplete breech, and that's where the presenting part is one or both of the feet. And then the final type would be a frank or extended breech, and that's where both of the fetus's hips are flexed and both of the knees are extended. This type of breech presentation is particularly significant clinically because these babies are at higher risk of developmental hip dysplasia. So they'll need screen for that after birth. So what are the risk factors then for breech presentation? So they can be divided into maternal, fetal, and placental. So on the maternal side, if the woman is multiparous, if she's had lots of pregnancies previously, if she has a history of fibroids, if she's had a previous breech pregnancy, or if there's any abnormalities of the Mullerian duct. On the fetal side of things then, a preterm baby is obviously smaller. There's more room in the uterus for them to turn around, so they're more likely to be in breech presentation. A macrosomic baby is also slightly more likely to be breech, or if it's a multiple pregnancy, there's a good chance that at least one of the babies will be breech. Placental factors then, if there's a placenta previa present, then that baby is more likely to be breech. And if there's any abnormality of the volume of amniotic fluid, so both polyhydramnios and oligohydramnios. Now, the significance of a breech presentation will very much depend on gestation. So at less than 36 weeks gestation, it's not really clinically significant unless we're planning early delivery. As I said, before term, babies are smaller, they have more room to turn, they can get themselves into a whole host of different positions, but they will often turn spontaneously to a cephalic presentation as they get closer to term. If that doesn't happen, if we reach 36, 37 weeks and that baby is still breech, then we can offer the woman an external cephalic version, which I'll talk about a little bit more in a moment. Sorry. That's offered at 36 weeks for women who are in their first pregnancy, 37 weeks in subsequent pregnancy. If that ECV, if that external cephalic version fails, elective cesarean section is usually recommended. That's because if you're attempting a vaginal breech delivery, there's a significantly increased risk of fetal entrapment, so where the body delivers but the head doesn't, and subsequent risk of that baby asphyxiating and passing away during delivery. If a vaginal breech delivery is going to be attempted, that absolutely has to involve some very, very senior obstetric and midwifery staff who are trained, who are knowledgeable about these things, who have experienced it before. It has to involve access to an emergency theatre with anaesthetists in case something goes wrong, and it has to involve access to a specialised paediatric team and a neonatal unit. So what does ECV involve then? So ECV is essentially an attempt to turn the baby into a cephalic presentation, so head down, by manipulating the pregnant person's abdomen. And it's done usually under ultrasound guidance. Again, if you get the chance to see this during your placement, it's really worthwhile going to see. I got to see a couple during my obs and gynae placement. So the process of that, what will happen is the woman, she'll come in for an appointment, and she'll receive a period of CTG monitoring right before, just to check that everything's okay with the fetus. She'll then be given tocolysis with terbutaline before. So tocolysis, that's just a medication given to relax the uterine muscles to make that manipulation as easy as possible. Then the obstetrician will apply pressure to the abdomen in an attempt to turn the baby around, head down. It can be quite painful for women, and they'll usually need some form of analgesia, whether it be usually things like Entonox or gas and air should be provided. ECV's got about a 50% success rate, so not great. That success rate is higher in women who've been pregnant before, so multiparous women, and that's just because their uterine muscles are a little bit more accommodating. They've been stretched previously. They're more used to being manipulated, so that's easier to do. The success rate's lower in women in their first pregnancy because of that. And then, as I said before, if that woman is rhesus negative, she will need anti-D and a Kleihauer test after any attempt at ECV, and that's whether that attempt was successful or not. She'll still need it regardless. Important to note the contraindications to ECV then. So any antepartum hemorrhage, any suspicion of ruptured membranes, if the woman's had a previous C-section, and that's because the muscles of the uterus are not as intact as they normally would be, they've been previously separated, then they're not going to be as strong. Any significant structural abnormality of the uterus would be a contraindication to ECV, so that would be things like women with large hemorrhoids or a bicornuate or heart-shaped uterus. A multiple pregnancy, so twins, triplets, anything like that, cannot have ECV. Or if there's any suspicion on CTG monitoring that all isn't perfectly well with the fetus, so any abnormalities of the CTG would be a contraindication to ECV. And then following the ECV, the woman will again receive a period of CTG monitoring just to ensure that the process didn't upset the baby any, didn't distress the baby at all. And then, provided if it was successful, she is good to go on her way and await spontaneous labour and hopefully a successful vaginal delivery. If it was unsuccessful, then, as with previously, the options are an elective cesarean section or a vaginal breech delivery if that's the route that the woman wants to go around. So that's the end of the presentation. I hope I've given you a fairly good overview of the basics of antenatal care here in the UK. If anyone has any questions, feel free to pop them into the chat now. And if not, I hope, as I said, I hope it's been useful. I wish you the best of luck with finals. And I do hope you will join me and my co-host Joelle. She is one of the other Mind the Bleep Obs and Gynae leads. She'll be hosting our next section, our next lecture, which should be advertised. If it's not already advertised, it'll be up soon. We'll be alternating, so she'll do the next one. I'll be doing the one after that, and I really hope you will all join us for those. All right. Feedback link. There is a feedback link. I'll just pop it into the chat now. Everyone is able to see that. Any feedback would be much appreciated, by the way. If you want to let me know anything that you think should be covered in future lectures, anything you think that we've missed, or anything that you think could have run better, would be great to know about. All right, guys, have a lovely night, everyone. All the best, and I hope to see you all again soon.